Afternoon, good morning, good evening, depending on where you're calling in from. My name is Grant Lippman. I'm going to be the moderator for this session. This is the oral abstracts on health policy and health services research. The format is 10 minutes per presenter, and there's going to be 2 minutes of Q&A after, so feel free to put all your questions in the chat, and then I'll moderate the questions once we're all done. So the first presenter is going to be Dr. Scott. There we go. Hello.
Hello.
And he's going to be lecturing, presenting on hospital SEP1 performance is negatively associated with emergency department flow.
Thanks, Dr. Lippman. I don't have permission to share my screen. Is someone able to grant me that?
Doug, are you able to grant him permission to make them the speaker's co-hosts?
Oh, there it goes, it looks like. All right. Just a second. Okay. Very good. Are you seeing my screen come through now? Awesome. All right. Thank you. Thank you to SAM for having me share this work, and for you all attending. I also want to thank my co-authors, Michael Puskarich and Saya Nickpay. I'm Nate Scott from Hennepin Healthcare and the University of Minnesota in Minneapolis. All right. On background, in 2016, CMS instituted a quality measure called SEP1, which is a measure that evaluates a bundle of process measures for the care of patients with severe sepsis and septic shock. This is something that's part of multiple quality programs, including the CMS Star Ranking Program for hospitals, which certainly some of our administrators and possibly some of ourselves hold near and dear to our hearts. Without going into the bundle in great detail, I think it is worth at least mentioning that the measure is for patients with sepsis, and it applies to care at the time at which sepsis is diagnosed. Now, for most patients that fall into this measure, they are diagnosed with sepsis at the time of arrival to the hospital, i.e. the emergency department typically. And there's a number of elements of this bundle that require very timely care: fluids, blood cultures, antibiotics, measurement of lactate, all within several hours of presentation. And for the most part, this care that goes into the measure is all taking place in the emergency department, with a minority of care taking place elsewhere in the hospital. Since this measure has come out, there has been noticed that there's quite a bit of variability in performance on this measure between different hospitals, and different researchers have sought to try to explain this variability. And there have been different correlations that have been found with different characteristics of hospitals with this measure, including for-profit status, case mix index, size of the hospital, and teaching status. We also know from the flow literature that poor ED flow is associated with a number of different things, at least in the described literature, include increased mortality, length of stay, cost, and poor satisfaction, or poor patient satisfaction. And so the primary study question that we sought to answer were, are these publicly available measures of ED flow correlated with hospital level SEP1 performance, noting that much of this care is happening in the emergency department and needs to occur in a timely manner. To answer this question, we primarily used the CMS Hospital Compare 2020 dataset, which includes a wide range of publicly reported quality measures, including performance on SEP1, as well as several measures of ED flow, in addition to other characteristics. We also included a data set from the US Census Bureau that looked at county level poverty rates, and included that as one of our variables as well. Primary outcome is hospital SEP1 score, and the primary mode of analysis was a multivariate regression. The ED flow variables we utilize include left without being seen, time from arrival in the ED to discharge, time from the admission decision to admission, and the volume category of the ED, reflecting categories of number of annual visits. We included a number of other confounding variables which had been previously demonstrated to be associated with SEP1 performance. In the data set, we had started with 3,200 hospitals approximately, and filtered down to 2,700 after excluding those that did not have an emergency department and did not have a SEP1 score in the database. Now, there's approximately 6,000 hospitals in the US, so this actually represents a fairly broad section inclusive number of hospitals. What's missing here is some hospitals that either don't participate in Medicare or aren't required to participate in the inpatient prospective payment system, so such as critical access hospitals or VA hospitals. Table 1 characterizes the hospitals that were included in this study. For the most part, these are nonprofit hospitals, slightly more than half in rural locations, with about 200 beds and about 13% of the patients in the counties in poverty. In terms of the ED flow characteristics of the hospitals, the majority of the hospitals included were what were considered our medium volume EDs, which to CMS is between 20,000 and 40,000 annual visits. The mean left without being seen was 1.6%, and time from decision to admission and time from discharge, as you see there, 120 and 156 minutes. I have just a couple of graphics showing the relationship between some of the categorical variables and distribution of SEP1 scores. This demonstrates that for-profit status of the hospital is associated with a higher mean SEP1 score, which is comparable to what we've seen in previous literature. Here, the more inpatient beds a hospital have, typically the lower the SEP1 score performance on that. Again, higher is better in terms of a SEP1 score. And then the relationship with ED volume is a little bit more complex, but we see both very high and also low EDs seeming to perform a little bit worse. All right, this is the results of the primary analysis that we looked at, which is the results of the multivariate regression looking for independent associations with these variables. And what we see here is that emergency departments with volumes either considered medium or high, which is 20 to 40,000 or 40 to 60,000, tend to perform better in terms of their hospital SEP1 performance. This coefficient is in relationship to a low emergency department volume. And very high seems to perform worse than medium or very high. I've bolded the variables for which the 95% confidence intervals do not cross zero, indicating a statistically significant relationship. For the three variables, time from decision to admission, time to discharge, and left without being seen, there we see the primary finding that we're reporting is that negative association with SEP1 score. So as flow worsened, as measured by these variables in the data set, SEP1 performance for the hospital also worsened. Some of the other variables also came out as having statistically significant independent associations, which is not surprising given some of the previous work that's been published in this area regarding for-profit status, number of beds, and then the relationship with poverty index. If your hospital was located in a county that had a higher percentage of people in poverty, they tended to perform worse on this measure. Our main finding as such that hospital SEP1 performance is negatively associated with publicly available markers of ED flow. This is independent of other characteristics. This finding has a certain face validity to it. We know that this care requires timely recognition and management of patients with sepsis. Most SEP1 care happens in the emergency department. And to our knowledge, this finding has not been reported in this manner previously. Some limitations, of course, given the nature of the study, there can be no inferences made about causality. There are most certainly other confounders that we did not measure or could not measure given the way this study was structured. Data are hospital level averages. So as such, we're looking at averages and averages. as such and not down to the level of individual patients. And of course, there's just some question about whether we should care about this at all, given that SEP1 is a process measure and not an outcome measure. And there's some question of that relationship from the process measure to the outcome. Further comments in the discussion. SEP1, given the tremendous variability we see in all these different associations, it may be measuring something that's not really that different due to differences in clinical care. There's other factors likely at play here. Or also another question is to infer, is there something about hospital with better flow reporting that also leads them to report higher SEP1 scores that we just don't understand that's at play, in addition to the obvious conclusions that there might be delayed recognition, delayed treatment, or other factors. And so this study raises some further question to try to unpack what factors are going on here. Is it indeed delayed recognition, delayed treatment, or other factors? And then would improvements to improve ED flow actually result in improved SEP1 performance? Is this an argument you could make to hospital administrators to do the things that we know work for ED flow, and this be a potential beneficial outcome for that? Thank you. Happy to take any questions.
Thank you very much, Dr. Scott. Really interesting study. I have a question for you. I'm waiting for people to kind of add in the chat. It looked like the strongest correlation there or association was with left without being seen, because the other ones really bridged on zero. And in that group, which was really impressively associated with poverty level, do you know if there's a higher poverty, if there's a higher left without being seen in poverty level, higher poverty level areas?
No, that's a great question. We didn't run that analysis to answer that, but I'll add it to a list of things to take a look at here. That's a great question to ask. Any other questions I can answer? Well, thank you all again for the opportunity. It's been a pleasure to share this with you.
Thank you very much. The next presenter is going to be Dr. Shea, who's going to be presenting his research on implementation of a vertical split flow model for patient throughput at a community hospital emergency department.
Okay, so let me see if I can share my screen. Okay, can everyone see the PowerPoint?
Yep.
Yes, okay, so hi everyone. My name is Al Shea. I am an emergency medicine resident at St. John's Riverside Hospital, just outside of New York City. I just want to thank SAEM for giving me the opportunity to share my work, as well as thank my co-authors for contributing to the research. Today, I'll be presenting the research investigating the impact of vertical split flow implementation on patient throughput at a community hospital emergency department. I do not have any financial conflicts of interest to disclose. And some abbreviations that I will be using throughout my talk include ED, standing for Emergency Department, VSF, standing for Vertical Split Flow, and ESI, standing for Emergency Severity Index. So overcrowding in emergency departments has become a significant public health concern due to the increasing demand for healthcare, shortage of staff, and available beds. The split flow model has been adopted at several hospitals to reduce variations in care and streamline patient flow through the ED by separating high and low acuity patients, such as the use of fast track. Vertical split flow refers to the concept of assigning patients to vertical chairs instead of horizontal beds based on patient acuity. This redesigned space aims to decrease patient length of stay and increase patient capacity for a subset of patients who do not need to lie down. despite a few studies analyzing throughput or patient flow at large tertiary care centers, there has not been any published literature evaluating the effectiveness of vertical split flow on patient throughput at a community hospital. So the objective of this study was to evaluate the impact of vertical split flow implementation on ED patient length of stay and throughput at a community hospital. This was a retrospective cohort study of all medium acuity or ESI level 3 patients presenting to a community hospital over a 3-month period before and after vertical split flow implementation between 2018 and 2019. And just to explain what ESI is, ESI stands for, I guess, Emergency Severity Index. It is a commonly adopted triage acuity system that differentiates patients based on patient acuity and resource utilization. Often you will see patients on your tracker from values from ESI level 1 to 5, with 1 representing the sickest and 5 the least acutely ill. This triage protocol is great at prioritizing treating the sickest patients first, but it does prolong wait times for less acute patients. And this is why ESI level 3 patients, they do often have the longest wait times because they're not sick enough to be cared for, or they're too sick to be cared for in the fast track areas, but they are placed at a lower priority for regular ED beds. And then again, a vertical area with 10 chairs was separated from the existing ED space and staffed by reassigned advanced practice providers. So to give you a bit more of a visual, here are 2 pictures. And on arrival, these ESI level 3 patients, they were assigned to a chair in the vertical area by the charge nurse if they could maintain a sitting position during treatment, did not require cardiac monitoring or airborne precautions, and presented no detectable risk of harm to self or others. So as you can see in these pictures, there are patient chairs along the walls that are separated by curtains for privacy, as well as a separate physical exam room. Patients, they were pulled into the separate room for registration, provider evaluation, laboratory work, and electrocardiograms, and then moved back to the vertical area to wait for radiographic testing, lab results, or medication administration. So unpaired t-tests compared time intervals between cohorts, with the primary outcome being total ED length of stay. That was defined by the electronic medical record timestamp from patient arrival to disposition, such as admission or discharge. Secondary outcomes looked at throughput using time from a patient arrival to bed placement and provider reassignment. So looking at the data, approximately 10,000 patient visits were included in analysis with 5,300 patients in each cohort. There are no significant differences in patient demographics between the 2 groups. Although there was an overall reduction in total ED volume by 4% between 2018 and 2019 due to a blunted flu season, most of the reduction came from fast track visits with only a 1% drop in main and ED and vertical ED volume. So looking at the results, the main finding was that there was a significant reduction in mean overall length of stay by 32 minutes from 283 to 251 minutes after vertical split flow implementation. And then breaking down the length of stay, after VSF implementation, patients were assigned to beds and completed their ED workups to reach a disposition more quickly, despite a small increase in bed to provider time. So in conclusion, community hospital ED implementation of vertical split flow for ESI level 3 patients was associated with significant reductions in overall length of stay and improved throughput. This model provides a solution to accommodate more patients and treat more efficiently without adding any physical space or providers. Having a single provider staffing the vertical area may have contributed to the small increase in bed to provider time and limited the number of vertical patients that can be triaged simultaneously. Some limitations of the study include adjusting hospital staff to the new protocols, as well as being unable to delineate what aspects of the vertical split flow, whether it's space rearrangement or provider reassignment, were the most crucial in terms of reducing length of stay. And as well as additional research can definitely look into this area and look at impacts on patient satisfaction scores, as well as clinical outcomes. So that's all for my talk. Does anyone have any questions?
Here's a question from Dr. Solnick. She was curious if there's any pushback from attendings on implementation of this process.
I think that with any, well, that's a great question. I think with any kind of change in ED flow, there's always some kind of pushback. I think I'm obviously one of the residents working in that ED, and I think over time, both the attendings and residents actually appreciate having the vertical space created, because with a single advanced care provider dedicated to treating patients in that area, the residents and attendings can really focus more of their attention towards higher acuity patients in the main ED.
To speak to that, I wasn't clear, was there an APP working these type of patients or an area before it went vertical?
Yes, so before, I guess before this space was created, there space was designated as there were additional beds in this area, and APPs were originally assigned to pick up lower acuity, I guess level 3, 4, 5 patients throughout the entire ED. So I think after the space was created, they did not see any patients who were placed in horizontal beds in the main ED and were reassigned to solely staffing the vertical area as well as the fast track area.
Okay, so there's a change of staffing and demographics or geography,
yes,
as well as or vertical versus horizontal orientation.
Yes.
And I'm curious, clinically, there have been done some studies on this from private hospitals to some large studies done in Texas, and the difference in length of stay range from 17 to about 40 minutes or so. You're kind of right in the middle. Did you have a priori amount of time that you thought would be clinically significant to improving the length of stay?
That is a good question. I don't have a specific number or specific number or threshold that I think we should all aim towards. Obviously, the bigger the number, the more evidence that the more motivated administration, as well as will be the more motivated administration will be geared towards creating this space. But again, I think with this, in this specific study, this study looked at all ESI level 3 patients. So these are patients who are seen in vertical area as well as the main ED.
Great. Any other questions? Thank you very much, Dr. Shea.
Okay, thank you.
So the next presenter is going to be Dr. Solnick, who's going to be talking on her study, Concerns about the Cost of Emergency Department Care, a National Survey of Older United States Adults, and this is sponsored by AAAEM.
Hello, can everyone hear me? Great, I'm just going to quick slideshow. All right, and hopefully that shows, oops, sorry, this presenter mode. Let me switch to the not presenter mode. Play from the start. Oh shoot, is it still showing the presenter mode?
Yes.
Let's see, play from current slide.
Hey, Rachel, if you click, oh, you got it.
Oh, is it showing? Because I'm still seeing presenter mode.
No,
No.
there's a
What
little
did you-
square icon on the bottom next to the slider. I think that one.
Shoot.
Did you
It's
click
gotta be
swap
what is my
display?
swap displays? Yeah, I think that must be it. Great. I think hopefully you guys are seeing the right thing now. That was all part of my stalling tactic, so I didn't get any questions in the end. Ha ha ha. All right. Thanks for waiting. My name is Rachel Solnick. I am currently a fellow in the National Clinical Scholars Program at University of Michigan. It's a health services research fellowship. And I'm going to be talking about costs of emergency department care and the findings from a national survey of older US adults. I have no conflicts of interest. So some background on this. So despite the ACA, which as we all know has made great strides in improving finances for individuals who are at greatest need for healthcare, we still see actually that medical issues are a key contributor to our bankruptcy. Americans have cited that 2/3 of the people who are having bankruptcy are saying that medical issues were part of that. And even despite most of the ACA's implementation in 2014, since 2010, we have seen an increase in family premiums for health insurance, raising 55%, which is twice the rate of wage increases since 2010. And as it makes sense, unplanned healthcare can cause financial hardship in terms of people that we probably see every day who are uninsured and have some sort of unexpected traumatic event, unexpected healthcare illness. And this financial hardship can in the future reduce care-seeking behavior. And older Americans with their lack of as robust income might have extra difficulty absorbing these unexpected emergency department costs. So the goals of the study were to understand what older adults' perceptions were for healthcare costs in the emergency departments, and how often are older adults saying that they're avoiding the emergency department due to cost concerns, and what are some of the variables that we have seen in other financial toxicity literature that we might see predictive of these extra cost concerns. And these are some things like sociodemographics, insurance, as well as health status. So to do this, we did a cross-sectional survey of older participants using a nationally representative probability-based panel in June of 2020. And I should note that this was actually a subset of a bigger survey on emergency department use as part of the University of Michigan's National Poll on Healthy Aging. And to conduct this poll, we partnered with Ipsos's Knowledge Panel, which does many of these surveys. And as part of their methodology, Ipsos weights the findings based on the US Census distributions. And so for the survey analysis, we did some basic, descriptive, and bivariate statistics. And then to see about some of these predictors of increased cost concerns, we did some multivariable logistics regressions. So our main outcome measures were these 4 questions. We asked in terms of perceptions of the emergency department bill. Thinking back to your last ER visit, what did you think about how much you had to pay out of pocket for your care? For cost concerns, we asked if you were deciding whether to go to the ER, how concerned would you be about the out-of-pocket cost of care? And we dichotomized that variable in order to do the logistics regressions into very concerned, and then the others were like somewhat or not concerned. For confidence and the affordability of the visit, we asked how confident are you about being able to afford your out-of-pocket costs for an ER visit if you needed to go? And that was dichotomized into not confident or otherwise. And then lastly, we asked about cost-related avoidance of the ER. In the past 2 years, was there a time when you thought you needed to go to the ER, but did not because you were worried about the cost? And that was just asked as a yes or no. So in terms of the respondents, we Ipsos did a random sampling of 2,777 and of those, 2,076 participated. It's harder for these probability internet-based panels to calculate a actual response rate. And so what they offer is a completion rate, which was around 70% or so. And this was planned to only be from US adults age 50 to 80 years old, and our mean age was 63. It was about half female, 40% had only a high school education or less, 20% were from households that made less than 30,000 K a year. About 20% had reported for fair to poor physical health, 8% fair to poor mental health, and we had the following race and ethnicity distributions, pretty similar to the US Census in terms of 70% white and 11% Black, but less in terms of 11% Hispanic. So in terms of perspectives for the emergency department bills, we asked this of everybody who had reported at least one ED visit, which was 538 participants, 27% of the full sample. And about 1 in 5, 21% reported paying a higher than expected bill. About half paid what expected, 12 paid less than expected, and 19% actually said no bill, which might make sense in the consideration of if they were a Medicaid payer. And we found that in bivariate statistics that there were the under age 65 group, so like the younger group actually had higher than expected bills. They reported it 27% of the time versus those over 65 only reported higher than expected bills 15% of the time. And perhaps not surprisingly, the lowest income group, those making under $30,000 a year, they were the group least likely to say that they had a lower than expected bill. Only 8% of them said that their bill was lower than expected. Moving on to confidence and ability to pay as the outcome, we found a fair amount of people saying that they were not confident. About 1 in 5 was not confident about their ability to pay for an emergency department visit. And then the rest were somewhat to very confident. In terms of the multivariable logistics regression that we have here on the right, I use the term protective. I know it's not a causal thing, but just to be brief about it, variables that were associated with less likely to be not confident or actually older age, as we would expect, higher income, and employer-sponsored health insurance. In terms of variables that were sort of detrimental to this, and this was something we actually found across the outcomes, female gender was associated with increased lack of confidence in ability to pay, not surprisingly uninsured. And then actually we found also poor to fair health was detrimental here. In terms of concerns for the affordability of the emergency department visits, about half, 45% said they were very concerned about their ability to afford a emergency department visit. And as seen in the previous outcome as well, those under 65 were more frequently reporting high concern, 50% of those under 65 versus 36% of those over 65. In the logistics regression, there's some overlap again in the associations where increased age was actually protective. Also higher incomes, or not surprisingly, public insurance as well as employer insurance were all protective of having high concerns for ED costs. And then those that were detrimental to this were again female, and then this time around the Hispanic population. In terms of this last outcome was cost associated emergency department avoidance. And so somewhat unfortunately, we asked this of the entire sample. So of everybody who said that they might potentially have needed the emergency department, of which that wasn't necessarily everybody, 7% said that they would have avoided the ER in the past 2 years because of cost. And not surprisingly, we found in the lowest income group that there was the highest amount of avoidance, with 10% saying that they've missed the emergency department due to cost. Again, just to run through some of these variables that were protective, not surprisingly higher income, but also Medicare insurance here was protective of avoiding the ER. And then for detrimental variables, again, we saw that it was females, as well as uninsured and those who reported poor to fair mental health. Of note, we saw that mental health, this was actually one of like the strongest outcomes, as well as uninsured status here in avoiding the emergency department due to cost concerns. And so in conclusion, we did find sizable proportions of older adults having cost concerns, some of which resulted in avoiding the emergency department even when they thought they needed to. 80% said that they were either somewhat to very concerned about the emergency department cost, and about 1 in 5 said that they were either not confident that they could afford the bill, or also just pay more than they expected. This matters in terms of policy implications, because as you may have been hearing over the past year or so, there's been a lot of talk about expanding the Medicare eligibility criteria down to age 60, which we saw, at least from the survey responses here, would be potentially protective of things like avoiding the emergency department due to cost concerns. And with that, I'd like to have some acknowledgements to especially the National Poll on Healthy Aging team, co-authors, and happy to take questions.
Great, thank you so much, Dr. Solnick. There's a question here in the chat that's asking, how do these estimates in the older adult population compare to other recent data from younger populations?
Sorry, can you repeat that one more time? I was like,
certainly. How do these estimates in the older adult population compare to other recent data from younger populations?
That's a good question. I think there's probably similarities. I am not as well versed at this point in the younger population, but there is a lot of financial toxicity literature, mostly from like the cancer, from like the oncology world. And we're seeing it more now also from like the trauma world. And I mean, not surprisingly, uninsurance status ends up mattering a lot. I mean, it's interesting in that we have this sort of like cutoff in the older population at this like 65 age mark to get some of these interesting comparisons in these age groupings that we wouldn't have in the younger populations. But I think there would be less potentially like care avoidance in this group because they're just less likely to have as many of like frailty and the comorbidities that are more common in older age, but definitely something that I can look into for comparison.
Great. First off, I got to say that getting a 78% response rate to a survey of this size is fantastic. Well done.
Note that's actually a completion rate, and so we partnered with Ipsos Knowledge Panel, and these that is like their business. They do similar to like Gallup polls, YouGov polls. They do these like nationally representative probability-based panels. So there's like a lot of like inner mechanics there. If you were looking at like the absolute response rates, given that this is like an sort of online based thing, it's actually closer to like 6%. So that is worth noting, and it's something that I need to like update in the abstract, because when they first reported, it was the response rate, and it's actually the completion rate. So
it's an interesting concept for people who do survey studies, maybe to consider if you can afford it, outsourcing your survey to professional group.
yes.
Thought that I had looking at this avoidance of 7% across the board. Were you surprised at that number?
Yes, that's, and especially because this is like a, in general, you could say sicker population in the sense that they are 50 to 80 years old. I had really, and this was just sort of a lesson learned in thinking about survey skip logics. As I'd mentioned, I really wish that I had asked, like, was there a time in the past 2 years in which you needed to go to the ER? Because that, if I had as a subsample of that, I think it would have been then even larger. So then 7% just across the entire population board, that's a lot. I mean, we saw with COVID in general, about 30% from what I've seen, reduction in ED visits. So I think that we could say that there is a lot of potential wiggle room in the population with their felt urgency in terms of how high of a boiling point things have to get until they go to the ER. So with that consideration, I think that 7% does make sense. I mean, in lieu of pandemic, concern for wallets made a 7% reduction. Yeah.
Great. Yeah, and I think that's a good point. The objective, actionable avoidance versus subjective concern would be an interesting outcome. But I agree. When you 7% on the face of it, it seems kind of small, but when you start thinking that maybe 20 to 25% would have, as many people would avoid an ED visit due to their wallet as opposed to a pandemic, it kind of puts it into stark relief.
Yeah, I mean, if you just also, just to piggyback on that, thinking about how 30% reduction has completely like destroyed employment prospects for this year and next year for emergency medicine, and has really changed like how we think about like what services we should provide in the emergency department. 7%, if we like fix that element, if everybody had like Medicare at 60, we would really then help our financial prospects in going forward, I think.
Great, thank you, Dr. Solnick.
Thanks.
The next presentation is going to be by Dr. Hawk, who's going to be giving us a talk on leveraging an online learning collaborative to pilot opioid-related quality measures for the emergency department.
All right, do you guys see my screen? Okay, perfect. Hang on, I gotta actually turn the light on in my office. What is? Apparently everybody's supposed to go home at 5 o'clock. So my name is Kate Hawk. I'm excited to be here today. I'm an assistant professor in emergency medicine at Yale, and I'm here to talk about our findings. So I don't have any conflicts of interest to report. I have some research funding from NIDA and FDA, and the work that I'm going to talk about today was been foundation funding by the Addiction Policy Forum and the Foundation for Opioid Response Efforts. So this is our team. This is really a project that's led by Arjun Venkatesh, who's the PI. I'm going to talk today about some data that we collected as part of the ACEP Emergency Medicine Quality Network. And this is our team, Scott Weiner, and I co-lead the steering committee. Craig, Megan, and Arjun are at Yale, and Dhruv and Pawan are associated with ACEP. So background, I mean, there's certainly a national interest in developing and testing opioid-related quality measures in the emergency department. But the feasibility of implementing and testing these related quality measures in the ED, particularly in sort of smaller and rural EDs, is really unknown. So our objective was to design and test the collection of feasible quality measures for safe opioid prescribing and to evaluate quality improvement amongst a cohort of participating EDs in an online learning collaborative. So the ACEP Equal Opioid Collaborative. So essentially this is an online collaborative where folks can sign up to participate in a essentially year-long structured quality improvement process. There are several different areas of equal collaboratives that are offered. I'm talking about data from the opioid one. And really the idea is to engage emergency clinicians and leverage EDs to improve clinical outcomes, coordination of care, and reduce costs. So over the course of this year-long participation, you have your first phase where an ED might decide to sign up, and you get, fill out an enrollment questionnaire and do some baseline benchmarking data. There's a learning collaborative that is sort of 6 to 9 months, depending on when you sign up. And there you have access to webinars and toolkits on online portal of sort of structured quality improvement activities. And you can collect CME for yourself and for other clinicians in your department. And there's sort of a wrap up where you submit some follow-up benchmarking data for which the golden ticket or golden apple or the drive for many of these medical directors for smaller EDs to participate in this is that they actually get CMS MIPS credit for participating in their structured quality improvement activity. So we leveraged our steering committee of national experts really around sort of the opioid space to develop these 6 sort of key pilot prescribing measures. They are pretty much exactly what you would expect them to be. If you've been sort of paying attention to opioid prescribing, its rate of prescription, pill count, documentation of medication safety. And these were really across 3 different conditions or ICD sort of buckets for ED visits: dental pain, atraumatic back pain, and atraumatic headache. And then we also looked at rates of opioid and benzodiazepine co-prescribing for patients who were seen in EDs for back pain. So the methods, so ED medical directors basically abstracted chart data from at least 30 charts with ICD codes consistent with back pain, dental pain, or headache in the pre and post collaborative period. And we calculated the opioid prescribing measure rates from EDs who'd submitted at least 30 charts at baseline and compared those to those who had submitted at least 30 charts at the end of the collaborative. And then there were t-tests to evaluate for differences between pre and post averages. So this is the description of the EDs that we were able to engage with. So we have data from a total of 340 EDs from around the country. As you can see, about 148 of them were from smaller EDs with less than 20,000 annual ED visits, and about 37% identified as rural. So these are the metrics for the data that we collected. And essentially, so the sort of just to orient you to the table, so we have sort of the ED opioid administration rate, alternatives to opioids, which is administering an NSAID or acetaminophen prior to opioid administration, or opioid prescribing rates. And essentially, we looked at sort of pre and post, after participating in the collaborative. So really, this idea was really a proof of concept. And we're not trying to prove that by signing up for the Equal Learning Collaborative, we are changing, this is not a causality thing. This is really more of a proof of concept around collecting data for these, this range of EDs. And so as you can see, we did actually see a decline in opioid administration rate for back pain, dental pain, across the collaborative period. We saw a slight increase in administration of alternatives to opioids and dental pain across the collaborative, and we saw a slight decrease in opioid prescribing rates associated with back pain. For the other sort of 3 measures we looked at, one was prescribed opioid pill count, one was medication safety, and then I mentioned the benzodiazepine and opioid co-prescription rate. So if you look for changes in this, the only statistical thing that we found was actually a decrease in the provision of medication safety education for people who were seen with dental pain, which is, it is what it is. And so that actually highlights, the fact that it's really important to sort of look at these measures in multiple different ways rather than just looking at raw changes across time. So there's certainly limitations to this analysis. I mean, participation is voluntary. People had to agree to sign up for Equal. They got to choose whether they did back pain or, headache, or they could have signed up for Stroke Collaborative or some other collaborative. Abstraction is not randomized. We asked folks to pick charts from the last 3 months, but didn't specifically say that it had to be this last 3, and we certainly didn't monitor that. It's a very short time frame, and obviously change is very multifactorial. We would never begin to presume that, in the year of 2017 or 18, that participating in our learning collaborative was wholly responsible for prescribing changes, but we know that it's important to measure them as they happen. And so this was a way for us to access a large number of EDs who don't necessarily provide data or engage in sort of these prescribing initiatives. So conclusions, we were able to design and effectively implement a collection of potential measures to evaluate opioid prescribing across a national sample of EDs. And this represents the first feasibility assessment of collection of measures from rural and community EDs that we're aware of. And we know that traditional quality improvement approaches were well received and appear to support local initiatives to reduce opioid prescribing. And with that, that's my email address. And certainly feel free to reach out if there are comments or questions.
Thank you, Dr. Hawk. I think we can all agree that this is a fantastic approach to a crisis. I noticed that if you look at the absolute change of the interventions, both with opioid prescribing as well as non-opioid use, the range was very similar, about 4 to 5% in the prescribing. So I think you mentioned the absolute difference is small. Do you think this is a way you could, do you think this is a limitation on the impact of this intervention, or rather, you sort of alluded to maybe, should be a different way of looking at these metrics, the absolute change?
So, I mean, as I mentioned, I think the really our goal here was to see whether or not we were actually able to do this, whether we could collect data, whether it would be reliable, and whether we thought it would actually mean something coming from each of these sites. You know, I think obviously if you were able to look at the same sites over a number of years, you know, you might actually be able to interpret, you know, have a better sense of real significant change that was happening in different specific EDs. But we know that change is certainly incremental. You know, these are the things that, you know, we find that, you know, that we think are important for this area.
Yeah, he says a feasibility study, it's a great shot across the bow to show you can actually do it. And then with a short amount of time and relatively small amount of charts, those all might be limitations on the data you can glean from. It's a great first step. And there's a question here in the chat. Has eQual considered partnering with insurers to help this fund work?
To fund this work or just work in general?
I believe
that's
this
work in
work was the
general.
Okay.
question. Oh, go ahead.
No. So we certainly, you know, what's interesting about this is you know, this work has been foundation funded. It started with Addiction Policy Forum and, you know, has now moved to FOR. What's sort of interesting is that when we initially launched it 3 years ago, people had a choice between whether they were going to provide data or sort of be on the track that was really focused on opioid prescribing, or we also had a whole other arm, you know, where people could talk about their care of ED patients after opioid overdose and initiation of treatments for opioid use disorder. We are presenting this data because like 85% of the EDs were like, we want to talk about prescribing. We don't want to talk about how we take care of patients after opioid overdose. And so with our shift in funders to FOR that is really more focused on sort of treatment engagement, our current collaborative year is actually focused more on sort of treatment engagement. And so, you know, we'll be collecting sort of data around, you know, naloxone prescription and referral for treatment after overdose and things along those lines. So we have not thought about partnering with insurers. Those of you who know Arjun, who I imagine many of you do, because he has a big voice and is incredibly brilliant, I'm sure he has thought about all the different ways to get at this and think about that. But we haven't specifically explored that.
Great, thank you so much, Dr. Solnick. The next presentation is going to be by Louisa Baidu, who's going to be sharing with us her research on police reporting and access to resources for domestic violence during the Chicago COVID-19 shelter-in-place order.
Hi, can you all hear me? All right, just gonna make this large. All right, so thank you for having me. It's really nice to be here with you all, and I really appreciate the opportunity to speak here. So my name is Louisa Baidu. I'm a third-year medical student at the University of Chicago, and this talk is titled Police Reporting and Availability of Resources for Domestic Violence during the COVID-19 stay-at-home order. Some of the topics we'll be discussing, particularly domestic violence, but also policing and COVID, may be difficult for some of us to discuss at the moment, so feel free to step away and take care of yourself as needed. And I have no financial disclosures to report. So domestic violence, which I'll be referring to as DV throughout, is typically underreported. Reasons for this may include a lack of support or trust when it comes to the legal system. Individuals may also fear that reporting will aggravate an abuser and increase violence severity. And finally, there's a lot of stigma around domestic violence. Individuals may not want to out themselves and feel pressure to handle the situation on their own. And underreporting is dangerous because it keeps violence a secret and acts as a barrier to resource access. And this allows violence to potentially escalate and cause serious long-term harm and possibly even death. Previous research has shown that domestic violence increases after disasters since individuals may engage in violence as a response to stress. And the National Domestic Violence Hotline indicated that this post-disaster surge was happening with the pandemic. Additionally, at least at our hospital in Chicago, ER workers have said that they felt like they were seeing more domestic violence cases. And a little bit about Chicago, it's divided into 77 community areas. The city can also be divided into a north, south, and west side. And this figure on the right shows the racial distribution of Chicago, with each color representing a racial or ethnic majority and each shape representing a community area. And as you see, the city is highly racially segregated. So on the north side, it's predominantly white, as shown in pink. The south side is predominantly Black, as shown in blue. And the west side is predominantly Latinx, Latinx and Black, as shown in orange and blue. And along with the segregation, you see disparities in poverty, policing, and COVID disease burden. Since the beginning of the pandemic, Chicago's predominantly Black and Latinx south and west sides have experienced more deaths from COVID-19 and reduced vaccine access. So with this background in mind, we wanted to ask, how are Chicago residents seeking help for domestic violence during the pandemic? More specifically, we wanted to ask question 1, which states, did individuals seek support from law enforcement? If not, we asked if there are other community resources available for them to access, which is question 2. And we hypothesized that domestic violence help seeking from police, which we measured using police reporting data, would increase because the pandemic increased stress levels and opportunities for conflict as individuals were isolated at home with their abusers. We also hypothesized that domestic violence community resource availability would decline as organizations complied with social distancing measures. Additionally, we sought to understand the influence of race and ethnicity on police reporting and resource availability. So study design, our primary data source was Chicago Police Department crime report data. This domestic violence data focuses primarily on physical violence in the home, and we utilized a community resource database, NowPow, to analyze community resource availability. We used a quasi-experimental longitudinal panel design with 2020 as the intervention arm and 2019 as the control. And the stay-at-home order, which is referred to here as SH, went into effect in late March. So for each year, we analyzed the 3 years before and the 3 years after that time of year. We know Chicago experiences higher rates of violence in the summer, so this allowed us to control for any seasonal variation in crime. And our main analysis was a mixed effects linear regression, including a number of covariates, including things like income, education, transportation use. And this allowed us to calculate an average treatment effect of the stay-at-home order at the community area level. So moving on to results, this figure here compares citywide domestic violence and domestic property crime reports. Dashed lines represent 2019, solid lines represent 2020. And while domestic violence up top increased in 2019, there wasn't any sort of similar increase in 2020. These two domestic violence, these red lines, show very different patterns as shown by the diverging V shape. And this is in sharp contrast to the yellow 2019 and 2020 patterns of property crime, which are so consistent that the lines are practically indistinguishable from one another. So there's something unique about how domestic violence was impacted by the stay-at-home order. And when we performed our regression, we found that indeed across community areas, domestic violence reporting decreased after the stay-at-home order. In red, you'll see the change in crimes per 100,000 people, followed by a 95% confidence interval. So this chart shows that domestic violence declined at an average rate of 21.8 crimes per 100,000. And when we looked at racial and ethnic differences, Black community areas reported significantly larger declines in police reporting. This blue box shows that police reporting in Black community areas decreased on average by 40.8 crimes per 100,000 people relative to white community areas. And that's a decrease which is nearly twice in magnitude of the overall trend. In the second part of our study, we analyzed 552 domestic violence community resources. Overall resource availability declined significantly by 5.1 resources per 100,000. Mental health and personal safety resources were particularly susceptible to closure during the pandemic. And this figure shows the change in domestic violence resource availability both before and during the pandemic. And this is again a map of Chicago with the shapes representing areas. And the most well-resourced community areas are shown in yellow and the least resourced shown in red. And you can see both before and during the pandemic, the north side was more resourced than the south side, and the south side, which is predominantly Black, became less resourced during the pandemic. And this is supported by statistical analysis showing that relative to the north side, south side community areas experienced a decline in resource availability at an average rate of 6.7 resources per 100,000. And before we talk about the main takeaways of our study, I'd like to highlight some limitations. Firstly, domestic violence incidence data is particularly difficult to obtain due to reporting barriers such as fear of escalation and fear of fear of escalation and stigma, as I mentioned before. So our work really is an analysis of reporting. And secondly, our police report data focuses on physical violence, which occurs in the home, but we know abuse comes in many, many forms. Additionally, we couldn't control for all real world variables. And we analyzed resource availability as opposed to utilization, and there was a continuously changing resource availability landscape. So what are our main takeaways? Domestic violence police reporting decreased after the stay-at-home order. The big question was, is this due to a true drop in incidents or an exacerbation of underreporting? And you speculate that it's caused by underreporting. We believe this is because the stay-at-home did isolate individuals at home with their abusers, and isolation is a key risk factor for domestic violence. We also know that there was a national increase in hotline traffic, and hospital employees have reported an increase in DV cases. And these factors point us towards incidents actually increasing. However, the pandemic essentially forced individuals to choose between their health and their safety. On the one hand, contact with police may have increased the potential for COVID exposure. On the other, involving police may have increased the risk of serious harm caused by abusers or even police. We believe this lose-lose situation forced individuals not to report to police. And our final takeaways touch on racial and ethnic disparities. While reporting and resource availability declined overall, these declines were particularly pronounced in Black community areas. Notably, the study period coincided with protests in response to George Floyd and Breonna Taylor's murders, and these events may have further eroded trust in police, particularly in Black communities. This decline in reporting associated with resource availability declines found on the South Side may have left Black communities in Chicago particularly vulnerable. And moving forward, we need to develop new ways of reporting and researching domestic violence. So individuals who can't or don't feel safe reaching out to police can still be connected to care. We need to explore the use of community resources as alternatives and adjuncts to police involvement. This includes expanding existing resources and introducing novel programs such as co-responder units in which behavioral health experts accompany police on calls. However, as these programs develop, it's important to question, one, how appropriate is it to allot more funding to relatively well-funded police forces, which many residents no longer feel safe with? And two, are we open to understanding domestic violence as more than an issue of criminality, but also an issue of behavioral health, poverty, housing, and employment, so that individuals actually can benefit from these community resources? Regardless, in Chicago, improved access to domestic violence resources, especially in Black communities, is vital and will likely require additional funding. Without access to appropriate resources, those experiencing domestic violence are at serious risk of harm. So it's incredibly important that medical professionals use their power to support patients before they reach our institutions seeking treatment for domestic violence, COVID, or any other ailment. And this can be done specifically by supporting and advocating for local policies that allocate and redistribute funds towards community resources. And with that, I'd like to thank my team at UChicago. If you have any questions or concerns, I'd love to hear them.
Thank you so much. Great work. It's so often in public health, it's hard to find a denominator that you can really compare things to. Sometimes you find a surrogate measure. It's interesting, as I was reading this 2020 study that looked at 14 large metropolitan areas that found a 7% increase in reporting during the shelter in place. How do you interpret the differences? Do you think they're unique to Chicago based on the demographics?
Yeah, so I think, and our team has talked about this a little bit, but I think Chicago really is, well, I'd say all of the cities are unique in their sort of relationship with police and how individuals are really choosing to make their decision making. So I think when you take all of their cities, there's a mixture of factors of like, what is COVID rates like? What do COVID rates look like in that city? How are people perceiving COVID risk? And then how are people perceiving risk when it comes to domestic violence and policing? So I do think Chicago is a bit of a unique story, but I also think this just focuses on a specific time period. So I think in all those cities, most likely, as the time has progressed, I think how people are interacting with law enforcement and hospital systems is going to vary.
Great. There's a question here. Do you have data on severity of injuries associated with police reporting? And if so, they're wondering whether these injuries were more severe post-COVID. I think by post-COVID might mean post-shelter in place.
Yeah, so I think that's something that we would love to have. I think that's something that would be good to like look at individual hospital data to find out. And our thinking is that sort of similar with the overall trend, we would expect it to be more severe. We did look at like homicide rates to get a sense of like overall trends in Chicago, and there was a total spike in homicides, but there weren't quite enough homicides to really. There aren't enough homicides, domestic homicides, to really draw strong statistical conclusions. But yeah, I think we would expect that severity would increase, but the sort of lower level injuries, like those people probably aren't presenting as much, as is the case with most injuries or illness in the pandemic.
Yeah, I think the question speaks as well to finding that surrogate measure they might be able to correlate with your findings, looking for some different markers to compare it to, which is always a challenge in this sort of work. But thank you so much. I appreciate it. Great job.
Thank you.
Our last presentation of the afternoon is going to be by Dr. Zhu, who is talking on change in emergency department visits from 2019 to 2020 by age and gender. And this is sponsored by AAAEM. There we go.
All right. Okay, so my name is Albert Zhou. I'm a second year resident at Morristown Medical Center. Today I'll be talking about the change in emergency department visits in 2019 to 2020 by age and gender. And I'd like to acknowledge my co-authors. So in terms of our background and objectives, so obviously we all know COVID arrived in the New York metropolitan area early in March 2020, and shortly thereafter, emergency department visits markedly decreased. So our goal was to determine if there were any differences in the decreases between pediatric and adult age groups, as well as between genders after COVID-19 arrived. So for our methods, we performed a retrospective cohort study of ED visits to 28 hospitals within 150 miles of New York City. The hospitals that we included were teaching or non-teaching and rural, suburban, or urban. Annual ED volumes range from 12,000 a year to 122,000 a year. And these were patients seen by ED physicians from March through November in 2019 and 2020. And we looked at the total number of ED visits and broke them down by age. So we broke them down between children, those who are aged 0 to 21 years, and then adults ages greater than 21 years, and as well as gender between the time periods from March through November in 2019 and 2020. And then we calculated the percent decreases from 2019 to 2020 for these ages and genders, as well as the differences in these percent decreases with 95% confidence intervals. So in terms of our results, there was a total of about 1.9 million visits between the 2 years, 1.1 million in 2019 and 800,000 in 2020. So this was a 30% decrease in overall ED visits from 2019 to 2020. And interestingly, the percent decreases in children and adults. So with children, there was a 52% decrease in visits, and in adults, there was a 23% decrease respectively. So this is a difference of 29% between the two groups. In children, there wasn't a big difference in the percent decrease by gender, 51% and 53% for females and males respectively, while in adult females and males, comparing ED visits between the 2 years, there's a decrease of 28% with adult females and 18% in adult males respectively, which is a difference of 10%. And this is just a graph that shows the total decrease and broken down by genders in the pediatric population and then in the adult population. So in terms of our conclusion, overall ED visits decreased from 2019 to 2020 with larger decreases in ED visits by children compared to adults. And by adult females compared to males. We speculated that the overall ED visits decreased because of public health mandates to isolate, as well as fear of contracting COVID-19. But interestingly, our data suggested that parents were especially cautious about bringing their children to the ED, but we didn't have an explanation for the greater decrease in visits by adult females compared to adult males. Thank you. Any questions?
Thank you so much. I think that certainly reflects all of our experience in the springtime. It was eerie, especially in the pediatric EDs. I'm curious if you are planning on doing any deep dives into the data in terms of either race or insurance coverage to see if you can find some more discrepancies or disparities on who was avoiding the ED.
I think, yeah, we didn't look into that, but I think that that would be a very interesting to look at that as well.
Well, one interesting thing that I've thought about and talked about people with is I have 2 young kids and they haven't really gotten sick in the past year because of all the different lack of interaction. So I just wonder if a lot of the diseases that would normally bring kids to ED just aren't happening as much.
Yeah, that's definitely a good point. Like even like the flu, we're not really seeing anymore because everyone's wearing masks.
You know, I think we all agree that the playground data is not going to be there, but you know, there's some anecdotal reports of increased amount of perf appies in the pediatric EDs during this time. Parents might have been scared to bring their kids in, so maybe you could look to see delayed presentation of certain injuries, like would there be an increased rate of perforated appendicitis, or something that would denote to a severity of impact of decreasing visits. I think that's a question for a different study. Any other questions? Well, thank you so much to all the presenters and for everyone to come and listen. And I appreciate everyone's hard work and excellent research. Have a good rest of your conference.
Thanks, you too.
Thank you.
Everyone.
Thank you.